morning. I'm Ali Fatemi from the Kennedy Krieger Institute, and I'm going to talk on behalf of Work Group 2 today, although it shouldn't really be me, but some of the people couldn't just make it, and so they figured I have a better voice. The Work Group 2 was basically following an initial problem that we were facing with ALD, that we are still facing with ALD, but not just with ALD, pretty much with many disorders, even if they're not rare. And that is that on when we think about the medical field on the research side, we have, see if this works, we have very good clinicians on one side that can do clinical trials, they can take care of patients, that have bedside manners and know how to do things right with patients. And we have very good scientists often on the other side where they know how to do research. They may not have bedside manners, but that's irrelevant because they know how to discover new things. They know how to go after new therapies. They know how to understand the molecular biology behind things. And the former director of NIH, Elias Zerhouni, he coined this term, crossing the death of valley. So this death of valley is really the problem here. The problem, getting it from a basic side to the clinical side. And why is there such problem? Well, there is many reasons, but part of it is that that we just need to gather data better in a way that it can be utilized in a standard fashion. And in addition to this general sort of notion, when we think about a disease like ALD or other leukodystrophies, and this is sort of a slide that is 15 years old. This is actually a slide I made for Hugo Moser in 2001. And unfortunately, it's the same problems that we're still facing today, is that it's a rare disease. And as you all know, the phenotype is very variable. There are individuals who are in their 60s running marathons with this disorder, and there are individuals who get affected at a very young age. And we still don't know, even though we've been studying this disease for so many years, we still don't know the detailed rate of progression to the extent that we can utilize to assess the effect of therapies necessarily. And as you all probably know, the mutation or any sort of biochemical assay currently existent for this disorder does not predict at all the outcome. So taking all this together, you're really facing a scenario that you have a rare disease and you don't have really good ways to measure certain things that you would like to measure. So we basically need to develop methods that allow standard collection of data. We need to develop methods that allow us to predict how a patient will do. And we need to develop things that will tell us how things will change over a short amount of time, because we can't afford doing trials that take 25 years. It's not good for the patients, it's not good for the investigators, and certainly it's not going to get funded and nobody will want to invest in it. So based on all these, really, Work Group 2 was established, we had, we still have these three sort of objectives. I'm not sure if we have hit any of the three yet, but we're working on it. So the first one is to establish what are the measures that we actually need to measure to know about disease progression on the research side and on the clinical side. Are there newer ways to collect data that will allow us to aggregate data more rapidly than before? And not only do we want to now look at the data that doctors can collect, but the data that the actual patients can report, because it really matters how the patients feel and not necessarily what we think is important. And on top of that, we needed to get away from the idea that, well, we are the noble academics and the industry people, they just want to make money. The bottom line is, as long as we don't collaborate together, we can't really move forward efficiently. And so we wanted to have industry input here because they know exactly what the FDA wants. They know exactly what the issues are on the regulatory side that an investigator may not necessarily know. So based on this, we basically put together a group of people, and some of them are here, multiple people I see in the room who are here. One person who should really give this talk was Jay Raymond, who couldn't make it, unfortunately. So he's at the University of Minnesota, he's an investigator. Kathy Zakowski is an investigator at Kennedy Krieger, who does a lot of quantitative measures, and many of the patients here have seen her as part of her study. Lena is sort of the guardian of Hugo's old database now for many years, and is really the person who has access to a large amount of retrospective data, historical data that were collected over several decades at Kennedy Krieger. And Chris Joseph is a physical therapist also down there who was very knowledgeable in different scales that people use for quality of life, for disabilities. And then we got an industry input from Steve Parker, who's also sitting here in the room, who really came to us and said, you guys can't be that arrogant. You need to listen to industry. And I think that was a very, very important input. And then, of course, very important to mention is Alex, who's sitting right next to us here. Alex came as a sort of a mentor here, and we're very fortunate that we have him in ALD Connect because he really had this great amount of expertise coming from the ALS world where they have already done what we are trying to achieve here. And so the idea, and this is really something that came from Alex, was utilizing a database that was already used in the past called Neurobank, which is a secure online database that has two portals. It has a physician portal where doctors and investigators can put in data, and on the other hand, patients can put in data. And the whole point is that we want to collect data across many sites the same way, so that when I see a patient, or if Florian sees a patient, and if it's even the same patient, we can put together variables so that when I see him at 0 months and he sees him at 6 months, we can still sort of use that data even though it's not collected at the same site. And one of the things that we found out very early, and so this was a series of phone calls over I think 6 months or 9 months, maybe 9 months, until we finally got together what are the core data points that we want to collect. One of the things that we realized is when you start working together, you can't just have a majority vote. You can't just say, well, the majority said this is what we should do and that's what we're going to do. You know, that works in politics, but that doesn't work here because everybody has to agree. So it has to be a consensus and not a majority vote. And so you have to really come down to a point where everybody can work together. And that's one of the biggest challenges, to find that, because we all have our own priorities. And coming to that point was certainly not easy. But we did that, however, for this database. And then the other thing that we started facing once approval to collect data, we realized, well, the ethics committees, they don't care. You know, Hopkins ethics committee doesn't give anything about what Harvard ethics committee thinks, and they're like, well, you know, they may say that's okay, but for us it's not okay. And so it took literally 6 months, if not longer, for us to get these IRB approvals across the different sites, which was a major hurdle. And finally got this approved in March 2015, which was one of the main reasons why also one of projects to kickstart this whole thing was being delayed. We were sitting there waiting for these committees that meet once a month to get back to us with, oh, you forgot the comma ups, you know, on the second page of your consent forms. And like, seriously? But that's the reality, unfortunately. So now there is this thing called Neurobank. We are already putting in data. We've been live now for collecting data for ALD patients. And in the last, I think, 6 months now, or 5 months. And so this is the physician portal. This is where the investigator goes in and puts in the data. And so far, these are numbers based on a week and a half ago or 2 weeks ago. So hopefully there might be a little more. So we had on the physician portal side patients that were entered in. Most of them were adults. And then there were 26 children in there. And then, like I said, it's very important now, even from an FDA perspective, there is a variable called patient-centered outcome measures. And that's one of the reasons why PCORI really was established, is to not only listen to the doctors, but what did the patients really think is the problem? Is it the same or is it something else? So we have the patient portal that's also really based on the backbone that already existed for ALS. And anybody can go online, and here is the link. If you are a care provider of a patient, or if you're a patient, or if you know somebody who knows a patient and they haven't done this yet, they should go to this website and basically sign up. You can also go to the ALD Connect website and sign up. So this has been online, I think, only since June, if not July of this year. And we have had 190 patients who went online and put in their data points in there. The majority of them were obviously adults, because it's hard for kids to put in the data. But though we have also many patients where we actually don't have the age. So that's part of the problem when you start collecting these big data sets, that not always your data will be as clear as you would like it to be. And so as a result of this, we can get variables like this very quickly. We ask the database manager just to spit out some numbers. So when you, for instance, ask how you walk, and you break it down into I walk well, occasionally unsteady, I require a wheelchair, I'm wheelchair bound, You can break it down by females, by males. The green one are the boys. And you can sort of do this. This is just an example of how you can quickly gather, aggregate data points and move forward. And then there's these surprises for us. For instance, as a clinician, we always fuss around how important, we think that all the disability skills are really based on walking. It's like, if you don't walk, you're disabled. That sort of was our perception. But when you actually ask patients, what matters to you most? You don't see the same distribution at all. This is important, this is somewhat important, this is not important. Walking is like this little thing down here. Comfort, pain, adrenal issues, energy, these are things that we didn't really think about as much, as we should have. And so that's really just to exemplify, and this is not necessarily good data right now, but what I'm trying to point out here is that if you start asking patients, you may be surprised about what matters to them, and it may not be the same. So it's key that we gather both data points. So how is that done from a technical perspective? I don't really have any clue about what I'm talking about right now, but Alex can explain that later in the afternoon. But the bottom line is that we have these different components of the database, and some of them are entered by a clinician, some of them are entered by a patient, some of them are entered by another clinician at a different site. And how does the database understand how to bring these data points together by something called GUID, which is a global unique identifier. And so this is basically a technology that Alex brought on that comes actually with some
from the NIH.
Okay, all right, with some some background from the government, I guess. And it's basically taking a number of socio-demographic variables that you put in, and based on those socio-demographic variables, you get a unique identifier. And so whether you go and see a patient in Minnesota, or if there's a patient, the same patient moves then to Boston, by putting in those demographics, the database understands, oh, this is the same person. And so it's key, because we want to reduce the amount of duplicated data points that are collected, and we want to have a clean data set as much as possible. So where are we going? Obviously, we need, as Florian mentioned, 5,000 patients. We have 190, so we have way to go here in terms of enrolling patients. There is only so much clinicians can do, because they can only put in patients that show up in their clinics. But there is the patient portal, and that word can be spread much easier, and we have had some campaign there to try to spread the word. And then, we hope that just this meeting is going to result in aggregating more data on the patient side. So these are two key issues here. We also are looking forward, obviously, to have more sites to join. This is not intended to be an exclusive academic relationship between 5 sites. This is meant to be an all-open consortium, and so if there are sites that have the qualification to be able to do this sort of work and want to join the consensus, we want to bring them on board. Then there's a lot of technical challenges, obviously. The data collections, that's a continuous process. This is not and we are good. You develop a database, the next day you have to already change it. And so we have, for instance, what we're trying to do is something called computational phenotype. So you put in the patient's age, the patient's symptoms, patient's MRI, and the computer is going to spit out, this is cerebral ALD, or this is Addison's only. And it seems simple, but it really isn't simple. And so we're working on trying to generate this sort of automated analysis as much as we can to, again, standardize the way the data is collected. And then one other issue that we are having a challenge with is that there is, like I said, this very large historical database that was collected over decades by Dr. Moser, by Lena, by Dr. Naidu, who's here, who's seen many of the early heterozygote carriers. And we're trying to see what can we do with this old database that is useful in a meaningful way today. That's again another big challenge. How can we import that into this neurobank in a standard fashion that can be usable and that does not violate any HIPAA rules, that does not violate any intellectual property, and so on. So that's pretty much it for workgroup 2, and I'm not sure who's talking for workgroup 3. Thanks.